Well, hello to you and welcome to this lecture. This is lecture number 5 in the Certificate of Professional Practice in the Epidemiology and Control of Non-Communicable Diseases. Now, before we start, as always, I want to take a moment to thank those who have made this lecture series possible, and that includes the Pacific Island Health Officers Association, the University of Arizona Zuckerman College of Public Health, the College of Micronesia Public Health Training Program, and of course my home institution, the Fiji National University School of Public Health and Primary Care. Now, without the backing of these institutions, then these lectures could not be provided. And of course, I want to thank you, the participant, for your dedication in improving yourself, no matter what your area of practice across the Pacific and beyond. I also want to thank the United States Centers for Disease Control and Prevention, from whom these lectures have been adapted, and I do want to point out that the opinions I express herein are my own and do not necessarily represent those of CDC, PHOA, FNU, or COM-FSM. Now, thus far in this lecture series, we've talked about an introduction to what epidemiology is and its importance to NCDs. We've reviewed the burden of NCDs in the Pacific with an emphasis on related risk factors, as well as the need for risk factor surveillance. We covered the burden of disease, including basic epidemiological measures such as incidence, prevalence, disability-adjusted life years, and so forth. And then we have also talked about different types of descriptive and analytical studies, which is what we did last month. Okay. Well, this month we'll be talking about how to analyze and interpret surveillance data. Now, it's important to keep in mind that gathering data is only one part of the process. To have a pile of surveys sitting in an office somewhere or data sitting in an Excel file, that's of no practical value to the overall goal of epidemiology and public health in the Pacific, which is that of enhancing the health and well-being of the populations that we serve through evidence-based approaches. Okay, now I do want to emphasize that something I keep talking about. We're really interested in doing things that have an evidence-based approach and not just trying random methods. We simply don't have the time, the money, and the resources to try random methods. Now, epidemiology, through data collection and analysis, is going to give us the evidence that we need to have targeted and effective interventions. And that's one of the take-home messages that I hope you're getting from these lectures. Now, like I said, the data we gather provides that evidence base, but only if we gather the data and then interpret what it means. It's similar to playing darts. Now, if I put a blindfold on and throw darts randomly at the wall, how many are going to hit the bullseye? Well, very few. It's the same as doing a public health program without data. In that instance, we're just guessing what the issues are, who they impact, and where our target audience is. We need to remove the blindfold so that we can see the bullseye that we're throwing the darts at. This is what we are doing when we analyze our data. We're actually looking at where the bullseye is so that our programs will have the intended impact that we desire. So what are our learning objectives today? Well, at the conclusion of this lecture, you, the student, should be able to do the following. First, describe what data is to be collected based upon the goal of surveillance systems. Okay, remember that with NCD epidemiology, we are more interested in gathering data on risk factors than actual disease rates. So can you recall why that is? Well, the reason for this is that since NCDs are insidious and take many years of risk to develop, it's better to identify risk factors that can be modified in order to prevent the disease, rather than waiting for the disease to happen when good outcomes can be difficult to obtain. Okay? Now, the second objective is that you should be able to identify how to present information from surveillance data, which in most instances will be descriptive data based around person, place, and time. Now, I hope you remember that this represents the descriptive epidemiology triad, where we present data as tables, percentages, and so on and so forth. And then third and finally, you will learn how to actually interpret what the data means to the populations you serve, and hence how this data can be used to design interventions, as well as implement policies and systems designed to alter behaviors, as well as the physical environments in which people live and work. Now, if you can do these things, then you'll be ready to use the data gathered by epidemiological studies to better serve your jurisdictions using what? Well, using an evidence-based approach to public health. So here is an overview of the specific topics that we're going to talk about today. So we will start out with an overview of data management, including sources of data and how the different sources impact the quality of the data. Now remember, when we're talking about data gathering, it's essentially like cooking a cake, right? If we put in good ingredients, then we're going to get a good cake. But if we put in pickles and hot sauce, then we're going to get a crappy cake out the other end. It's going to be the same thing with the sources of our data. If we put in good and complete data into our interpretation, then we will get a quality product that's going to allow us to make good or evidence-based decisions. However, if we put in bad data, say we don't collect the right kind of data or we don't collect enough data, then we're going to get bad evidence and hence our programs will not work very well. So do keep this in mind that the quality of data is going to be very, very important. Okay? We're then going to talk about how to analyze and interpret the data, including how to present the data in tables and graphs from the standpoint of descriptive epidemiology, which of course you remember is person, place, and time. And then we're going to talk about using data to identify risk factors. And finally, we're going to talk about limitations on interpreting our data. And that's going to be a particularly important section because, like I said, depending upon the quality of the data, if we've got good data, then we're going to have good interpretation. But if we have bad data, maybe it's incomplete, insufficient, not cleaned properly, then we're going to have bad interpretation and hence bad decisions coming out of that. So to start with, let's do a quick review of data management, and we'll do that in the following slides. Now, in general, there are going to be 6 categories of information or data collected as part of an NCD surveillance system. And these include identifying data, demographic data, clinical data, laboratory data, risk factor data, and of course, source data. And you can see all of those on the screen there. Now, let's talk about what each of these mean and give some examples. So, for example, identifying data might include an individual's name. If they're underage, it might be their parent or guardian if they're under age 18. Could include things like an address, a phone number, and so on and so forth. Now, some types of information that we can be used to identify an individual. And this is not necessarily a good thing because a lot of times when we're gathering data from people, especially if we're gathering sensitive data about risk factors, they don't want to be identified, all right? In fact, their willingness to give us information and participate in a survey or a study oftentimes is linked to their anonymity within that study. Okay, so I want to point out that in most NCD surveillance systems, it is not appropriate to collect identifying data. And the reason for that is because we're operating from a population-based standpoint, we're not doing clinical medicine here, we're not generally going to go back and offer individual interventions to these individuals. So if we identify a particular area of one of our islands as having high rates of hypertension, we're not going to go back and find individuals that have hypertension and provide them with interventions, okay? What we might do is go back and provide generalized information, health education, and different resources to that entire community. But in most instances, we're not going to be providing individual level interventions, and so generally we're not actually going to collect identifying data. Now, demographic data includes information on things like age and gender, ethnicity, educational level, and so forth. And it's going to be useful in identifying trends based around these criteria. So an example of that would be whether women have higher rates of a disease as opposed to men, whether a specific age range has higher rates, and so forth. Now, demographic data is particularly good data to have because it helps us support a specific hypothesis. Okay, let's say that we hypothesize that women living below a certain level of poverty are going to have higher rates of domestic violence. Okay, well, we can use demographic data when we go out and interview people to test that hypothesis. Okay, or it might be that we can use sort of a reverse engineering of what I just talked about. We can use demographic data to go back and generate a hypothesis as we analyze the information. Now, clinical data includes information on tests and other results. This would be like a chest x-ray if we're looking for pulmonary tuberculosis, glucose measurements for diabetes, and so on and so forth. We might call this biometric data in some cases. And of course, we also can collect risk information, and risk information would include, for example, information on family health history, behavioral risk factors such as smoking and diet, and so forth. Now, this is highly useful data when testing a hypothesis or when generating one in terms of identifying which members of a population have the greatest risk, okay, and hence should be the target of our interventions. Now remember, we are trying to do evidence-based public health here, so that's why risk-based information is particularly useful for NCD surveillance, because once again, we're interested in identifying people who are at risk for NCDs and intervening to prevent them from actually getting the NCD, as opposed to waiting for the NCD to develop. And what we'll do is we'll actually talk a little bit more about risk factor information later in the presentation, particularly given how important it is to NCD surveillance. And finally, our last category of data would be source information, and that includes where we're getting our information from. Okay, this would be things like, is it being reported by a physician? Are we getting the information from a dispensary, a hospital, a laboratory, survey of a village, whatever that happens to be. So there are the different types of categories of data that we would gather in relation to NCD epidemiology. Now, I do want to make a brief comment about confidentiality. Now, just as a nurse or a physician must maintain the confidentiality of the information they gather from patients, so must epidemiologists and public health practitioners. Now, you probably recall from the previous slide that I mentioned that gathering identifying information like name, address, phone number, and so forth is not necessary unless you're going to provide a specific intervention for people at a later date. Otherwise, since you're generally only gathering data that will be looked at from the standpoint of the population, and an example of that might be how many women in Saipan regularly attend prenatal appointments, okay? So because we're looking at data from the standpoint of the population, it is not necessary to gather personal information in most instances. Okay, so the take-home message is that you must ensure that all collected data is kept confidential. And in fact, many surveillance systems do not include fields for personal identifiers in order to protect the confidentiality. Okay. And that's particularly true in relation to NCDs. Now, if you had like a tuberculosis registry or something along those lines where it's dealing with infectious diseases, then you would be interested in personal identification information, because obviously you need to keep track of these individuals, do trace contacting, and so on and so forth. But that's a topic for more for communicable disease epidemiology as opposed to NCD epidemiology. So quickly, let's just delve a little bit further into why confidentiality is important. Now, people's health is private, and only they have the right to share that information with others, whether that's family members, their physician, whoever. Now, surveillance activities often collect data that could cause harm to the person if the information were disclosed. For example, a person diagnosed with a health condition, say HIV, for example, may not want that information to be revealed to someone such as an employer. Now, there are many ways to prevent identifying data from being disclosed, and one of the most common is to assign a unique combination of numbers and letters to each case or to record. So in other words, we're going to create an individual record number for each case. Now, this identification number may be assigned before the data is collected. So for example, if you're going to do a survey, when you send the survey to the printers, you might have them pre-print the identification numbers on the survey. It's a very convenient form and something I've done in the past. Now, in many instances, non-identifying information may be enough to infer the identification of individuals that are included in a survey or a study. So, for example, if you survey a village and the village, say, has less than 25 to 50 people in it, and there are only a few cases of a specific condition, then it becomes possible to identify those individuals. Now, generally what we do to avoid this problem is that if the number of people with a condition is less than 5 in a population, then you should not release the number of people for whom you have taken data. So let's talk about some issues with data quality, and we'll start with this concept of completeness. Now, completeness of data is important to the quality of the data collected as part of the surveillance system. Now, completeness can actually refer to a couple of different things. First, it can refer to the completeness of collected data in the surveillance system, or in other words, how much missing information is there in the system. Now, generally, if more than 10% of the data is missing, investigators become concerned about the validity of the data, as the population that they're studying may not be a true representation of the larger population. Okay. Now, this can impact the ability to practice evidence-based public health, because essentially if we don't have complete data going in, then the analysis we do is going to be flawed, and hence the programs that we develop based upon that evidence will also be flawed. Now, the second thing that completeness of data can refer to is the completeness of the reporting. Now, the ability of a surveillance system to acquire all the records of an event under surveillance also influence the quality of the data. So, for example, if infants born at home are not registered with the appropriate government offices, their information will not be captured by vital events registration data, and this could lead to an underestimation of births in a specific area. So let's take a look at an example of completeness. So these tables show the completeness of data collected by two different surveys, one on diabetes and one on asthma. Now, the diabetes survey had 1,000 respondents and the asthma survey had 2,000 respondents. So take a look at the two tables, okay? Now, are you concerned that the data missing from table 1 will affect your interpretation of diabetes by age and sex? Now, the missing data on sex is actually unlikely to affect interpretation of findings related to gender, because as you can see there, only 8.6% of the data is missing. However, 17.3% of data on age are missing, okay? Therefore, interpretation of findings for diabetes related to age may actually be limited. So there's that almost arbitrary 10% threshold, but we have to put a number somewhere, so do keep that 10% in mind, okay? Now take a look at Table 2. So kind of the same question. Are you concerned that the data missing from Table 2 will affect interpretation of asthma by sex or by age? More than 10% of the data are actually missing for sex. Even though we noted that missing data greater than 10% could limit the interpretability, this is not always going to be a strict rule. Hence, it is possible that the missing data on sex may or may not impact the interpretation of such. But since it's crossed that magic 10% line, you should consider whether or not you think that's a possibility. Now, one way of determining whether or not it's going to have an impact once it crosses that 10% line is to see if the missing 10% is greater than 10% different than the larger population that you're actually sampling. Now, it's important to consider this element when more than 10% of your results are actually missing. Can you hear the roosters in the background? There's actually no power today in Pompeii, so I'm working from home, but you can hear the roosters crowing in the background. You gotta love the Pacific, right? Now, like completeness, lack of validity also affects the quality of data, thereby hindering the interpretation of that data. So here are some common errors that can threaten validity. First, survey respondents provide inaccurate information, and this is sometimes called respondent bias. Now, this often occurs when the topic or the issue is sensitive and a socially desired response is clear. So, for example, let's say we're talking to diabetic patients, okay? And we ask the diabetic patients, well, are you going in to see the provider once a month for your medical evaluation? And of course, they want to please. They want to say, well, of course I'm going to see my diabetic specialist once a month. And so they say, yes, I'm going to see the diabetic specialist, when in fact they might not have been to see the internist or the endocrinologist in months or years. But because they think to themselves, this is what the individual who's conducting the interview wants to hear, or this is the individual who wrote the survey wants to hear, then they give that socially anticipated response. Now, the other thing to keep in mind is that data can also be recorded erroneously when they're being collected. So for instance, the data collector might inadvertently record a birth year as 1997 instead of 1957. And finally, errors may occur when data is entered into the computer database, and that's just simply a data entry problem. We're all human, and oftentimes we pay data clerks to put this information in, and there can be errors introduced in. Now, there are methods for cleaning and ensuring that the data is valid, but these tend to be beyond the scope of this lecture today. Okay, so now we're going to discuss analyzing surveillance data. And I want to stress that analysis using statistical software such as SPSS, Stata, or even EpiInfo is not the focus of this lesson. Rather, here we're going to discuss some basic descriptive analysis techniques that you can use using data that's generally organized by tables. And so I want you to keep this in mind as we go through this. I think a lot of times people assume that data analysis is a very difficult proposition. It involves statisticians and epidemiologists and biostatisticians and expensive computer programs, okay? When in fact, that's not always the case, because do keep in mind, here we're talking about descriptive data, person, place, and time. We're not talking about analytical data related to host, agent, and environment. Descriptive data is generally going to be limited to things like means and modes and things along those lines, which are easy to do using an Excel file or EpiInfo, and then gives you the opportunity to look at the results and make some type of interpretive decision on that. And that's really the focus of what we're talking about today. Now, let's talk about analysis in support of objectives. Now, knowing the goals of surveillance before data collection begins will guide both the type of data which is collected and the kinds of analyses that are going to be performed. Now, before analyzing surveillance data, it's critical to make sure that the analytic approach you take will be able to address the surveillance objectives. And when I say surveillance objectives, I'm just simply saying, what question is the surveillance system intending to answer? Because if you know the question that's being asked and what it's going to, what you ultimately want to answer, then that's going to dictate the type of data that you actually go out and gather and hence analyze. Now, the results of surveillance data analysis describe the distribution and occurrence of NCDs in a population. Now, surveillance data should be summarized and presented in a manner that is easy for the audience to understand and interpret, okay? Now, the audience can include program managers, it can include politicians, decision makers, and so on and so forth. Now, analytic results can be presented in some very basic ways that people are familiar with from reading newspapers and having been in school, and that are usually things like tables and graphs and charts and even maps. So, why is it important for decision makers to understand the analysis results? Well, one possible answer is so that the recommendations that you make based upon your analysis can be implemented, or so that the surveillance findings will actually be used, or so that the results will actually be disseminated to those who can make use of those results. And the key of doing that, once again, is that you present the data in usable, easily digestible formats. Now, for those of you who have undergone the data in decision-making training or are currently undergoing it, you'll understand what I mean. That's why the emphasis is being placed on producing an epidemiology surveillance product, such as a dashboard that's easy to use by the decision makers above you in the chain of command. And that's why you consulted these decision makers to say, what type of data do you need so that you can make better evidence-based decisions on how we run our programs across, whether it's Guam or FSM or CNMI or wherever it happens to be at that particular point. All right, now in the past we have talked about descriptive epidemiology, and we've called it the descriptive epidemiological triad, okay? And we called it that because of the three elements of descriptive epi: person, place, and time. Now we use these three elements to describe the distribution and determinants of a health condition in a population. All right, so what we're going to do now is we're going to talk about each of these elements in turn and how they relate to the analysis of surveillance data. So let's start with person. Now, person is the individual who is affected by a health condition or an event. Now, you may recall that one category of data collected in surveillance systems is demographic data. Now, person can refer to a variety of different demographic descriptors, and they'll include things like age and gender, marital status, occupation, level of education, number of children, and so on and so forth. Okay. Now, analyzing surveillance data by person provides further information on the groups of individuals that are affected by a particular health problem, and that in turn permits the identification of subpopulations that might be at higher risk for developing non-communicable diseases. So let's look at an example of interpreting person data here. So this table summarizes the prevalence of obesity among men aged 18 to 59 years old in Brazil during the year 2006. Now, what conclusions would you make about obesity prevalence in young men compared with the prevalence in older men in this sample? So why don't you take a second, pause the recording, look at the table, and do just that. All right, see what you can make out in terms of the prevalence of obesity in young men as opposed to older men in this sample. Okay, good. I hope you took a second, so we're back. Now, in general, the prevalence of obesity does what? It increases with age among men in Brazil in 2006. And men aged 49 to 59 have nearly 4 times the prevalence of obesity compared to men aged 18 to 24. So, having analyzed it and having arrived at that conclusion, what would it say? Who should be our target population in terms of an obesity prevention and control program in this particular area of Brazil? Well, obviously in terms of control, who would we look at? Well, we'd look at the man in the age 49 to 59-year-old bracket because they're already either overweight or obese and hence have increased risk factors for NCDs such as hypertension, cardiovascular disease, and so forth, okay? But in terms of actual prevention of obesity, who would we look at? Well, we'd look at the 18 to 24-year-old range because these individuals aren't suffering from obesity by and large yet, and so we want to see if we can develop programs to help them maintain healthy weights, all right? Maintain healthy behavioral choices related to diet, exercise, stress, and so on and so forth. All right, let's take a look at place. Now, place simply refers to geographically associated characteristics of what? The affected population. So, for example, where do they live? Where do they work? Where were they exposed to the independent variable? Where were they diagnosed? Where were they treated? And so on and so forth. So, a variety of different factors there. Now, maps can be a very useful tool for describing health conditions by place or by location. And in fact, it was Dr. John Snow, who's the father of epidemiology, who first used maps to describe the prevalence of cholera in central London in 1854, from which he was able to deduce the source of the outbreak as being the Broad Street communal water pump. Now, Snow was able to show that the largest segment of the affected population was getting their water from this single pump, and thus he was able to deduce it as the source of the outbreak. Maps are really a great way of showing information in a way that the eye might not see in a chart or a graph or even just an Excel file. All right, and our third element in the descriptive epidemiology triad is going to be time. Now, time refers to the period when an event occurred. So in other words, this could be things like when was the individual exposed to a risk factor? When did they see the onset of symptoms? When were they diagnosed? When was the case reported to the public health agencies? And so on and so forth, okay? Now, investigators are going to look for changes in the rates of health conditions over time. Okay, and we're going to call these trends. And the reason we do that is to determine whether or not disease rates or trends are stable, decreasing, or increasing. Now, you may recall from our earlier lectures that we can use terms such as endemic and epidemic to describe these changes. So let's look at an example of time. Here we see a graphic representation of time. Now this graph shows the rates for the 3 leading causes of injury-related deaths for persons over the age of 18 in the United States between the period of 1979 and 2007. So what conclusions can you draw about the death rates due to motor vehicle traffic, firearms, and poisoning in this period? So once again, why don't you go ahead and just take a second and pause the recording and just see what conclusions you can draw here. Okay, we're back. Now, one conclusion you might be able to draw is that the death rate due to poisoning increased from approximately 5 deaths per 100,000 in 1979 to approximately 14 deaths per 100,000 in 2007. All right, and then you would have to ask yourself, why? What is the underlying mediating reason that we actually saw an increase in the number of deaths due to poisoning? Okay, same thing you could do with the other examples here. You could state that the death rate due to motor vehicle traffic decreased from approximately 22 deaths per 100,000 in 79 to 15 deaths per 100,000 in 2007. What changed? Did the road system become better? Did people become more inherently aware of traffic safety? Did design in automobiles change? What are the underlying reasons for that? Okay, or a third conclusion you could draw might be that the death rate due to firearms decreased from 15 deaths per 100,000 in 1979 to approximately 11 deaths per 100,000 in 2007, although the death rate increased slightly in the early 1990s. Okay. So do you see what we're doing? We're actually analyzing the data by making the conclusions that are supported by various elements of the descriptive epidemiology. And we're doing all of this without using complex statistical formulas and without using computer software, okay? But because we've been able to organize the data that we've collected, we can draw conclusions. And from these conclusions, we can develop interventions. And because these interventions are based on data, what can we say? We can say that we're practicing evidence-based public health, okay? It's a simple but incredibly powerful tool. If you'll just take the data that you have and begin to do simple analyses using just descriptive data, you'll be amazed at what you can find out about the populations that you serve. All right, let's talk briefly about risk factors, and this is largely a review from one of the previous lectures. Like I said, it's particularly a review if you've had the previous videos, but it also is probably a review for those of you who have done the DDM course as well. Now, it's important in NCD surveillance to describe potential risk factors, okay? Now, unlike infectious diseases where specific pathogens cause specific diseases, NCDs are often the result of a number of risk factors. Now, these might include things like alcohol consumption, diet and nutrition, genetics, lack of exercise, tobacco use, and so on and so forth, all of which you are inherently aware of because you're practicing nursing or public health or medicine here in the Pacific, where it is a significant problem. Now, we also need to recall from our previous discussions the idea of modifiable versus non-modifiable risk factors. Now, modifiable risk factors, as the name suggests, and as we've talked about before in the past, are simply risk factors that can be changed, and they usually are associated with lifestyle choices, such as the extent of physical activity and choice of diet, and so on and so forth. Now, what are examples of non-modifiable risk factors? Well, non-modifiable risk factors are those that can't be changed, of course, and they include things like age, as much as you would like to change your age, okay, as much as people lie about their age sometimes, okay, it really can't be changed. Family history, and that would include a genetic component as well, ethnicity, as well as some biological markers, and gender as well, okay. Now, an example of hereditary or a non-modifiable risk factor is going to be the mutation that we sometimes see on the BRCA1 or the BRCA2 gene. And if a woman has these, then she has an increased risk for breast cancer, particularly if she's engaging in certain risky behaviors such as smoking or a diet high in fats and red meats, and she's obese as well. Okay. So let's look at an example of risk factors here. So here is an adapted table from a study of risk factors that was undertaken in the Middle Eastern country of Jordan, and it shows the relationship between age groups and high blood pressure. And I do want to point out this is self-reported and self-measured data, so it's already a little bit questionable, okay? So what modifiable risk factors might impact the data shown on the chart? Well, take a second and think about this, because we're talking about what? We're talking about hypertension, okay? And most of you already know what the risk factors are for hypertension. So for example, people can modify their eating habits or specifically their salt intake, which can impact high blood pressure. So then we also need to consider what non-modifiable risk factors are shown on this chart. Now this might include age and gender, both of which can be connected to hypertension, particularly age. As age goes up, we tend to see the rates of hypertension go up as well, and then also gender, we tend to see that men have higher rates of hypertension than females. So once again, you can see that we're using a representation of risk factors by what? Person, place, and time, okay, in order to analyze the data without statistical tests. But at the same time, it tells us something about what we can do in terms of program development and implementation to reduce the risk among the modifiable risk factors. Now keep in mind though that interpreting data about modifiable risk factors is easier than interpreting data about non-modifiable risk factors, okay? Now, recall that modifiable risk factors are those associated with lifestyle choices, such as exercise, diet, smoking, and so forth. Recommendations about modifiable risk factors are often encourage people to change these behaviors and to make better health-related decisions, whereas it tends to be more difficult to give people advice on non-modifiable risk factors, such as genetics and age. I'm not saying you can't, but it tends to be a little bit more difficult to do. Now let's talk a little bit about some of the limitations of surveillance data. And this is a fairly important section because even if we're just, we collect good data and we try our hardest, there's always going to be limitations to the actual data that we collect, okay? Now, earlier you were asked to interpret some tables, okay? Now, interpreting surveillance data is not always going to be as easy and straightforward as what we just did, okay? Now, the key to interpreting surveillance data accurately, though, is to know the limitations of the data that we've gathered. Now, the most common limitation to surveillance data that we're going to talk about here are going to be things like underreporting, okay, representativeness of the data, and changes in case definition. And what we're going to do is we're going to take each one of these in turn in the next couple of slides. So let's start with underreporting as one of our limitations of surveillance data. Now, like I said, underreporting is one limitation of surveillance data and one that many of you may be very, very familiar with because you work in public health. Now, this is a situation in which there is a failure to report data to proper officials, such as may be required by law, such as the National Notifiable Disease Surveillance System, all right, in which physicians and labs and other providers have to notify the public health system for things like influenza, Ebola, so on and so forth, okay? Now, oftentimes this underreporting is due to personnel being unaware of the need to report, okay? And it's going to be very common in passive surveillance systems. Now, you may recall that passive surveillance systems are ones in which the Public Health Agency relies on physicians and schools and clinics and so on and so forth to report data directly to them. In other words, the Public Health Agency doesn't go out and collect the data. They wait for surveillance sites to report that data in. So when we say passive, it's passive on the part of the Public Health Agency. They passively sit and wait for the data to be reported. Now, for notifiable and in particular mandatory reporting health conditions, it is the responsibility of the diagnosing physician or the medical facility to report that data. Okay. Now, sometimes physicians are not aware of the data they need to be reporting, or they may just not participate. And that can be understandable because physicians tend to be very, very busy people. But at the same time, we hope that they understand that we work hand in hand. The physicians and public health are part of a greater continuum of care. And a lot of times when we're asking them to collect data, it's so that we can help prevent disease, so that we can ease their workload, so that we can prevent this mass onslaught of diabetics that need their metformin and, they're waiting to have their feet cut off because they have diabetic, they've got gangrene, or they need to see the ophthalmologist because of retinopathy and things like that. So even though physicians are busy, we do hope that they understand the importance of reporting into surveillance systems, okay? And one way to help with this is periodic education of healthcare providers to help raise awareness of their duties and responsibilities in reporting this data. Now, representativeness is also a limitation of surveillance data. Now, representativeness simply refers to how accurately the data reflects the occurrence and distribution of disease in the population. Now, you may recall in a previous lecture we talked about population sampling, and the representativeness of the data is actually impacted on whether or not we use an appropriate sampling technique. Okay, so in other words, the more accurate the sampling technique, the more accurate the representativeness of the data is. So in other words, the more likely the small study sample we have is to represent the larger study population that it represents. Okay. Now, one of the goals of collecting surveillance data is to be able to generalize findings to the source of the population. So in other words, if I have a population of 1,000 people and I study 100 of those people, can I take the findings from those 100 individuals and then apply them to the larger population of 1,000 individuals? And if I've used the appropriate sampling technique and I have a good study design, then yes, I can do that at that point. So in other words, surveillance data that's representative of the true distribution of a disease in a population permits public health authorities to take effective measures to reduce the burden of disease, in particular NCDs. Now, when data are not representative of the true occurrence and distribution of the disease in the population, then estimated statistics such as prevalence rates may actually overestimate or underestimate the true burden of the disease in the population. And so we won't be able to appropriately design programs or direct resources to the appropriate area. And this may lead to implementation of prevention and control measures that may be excessive or actually inadequate. So two extremes there. Now, collecting data from a variety of sources can actually help improve representativeness. So in other words, if we want to look at diabetics and all we do is we collect hospital data, then we're missing a whole chunk of the population in the community that may also be diabetic or may actually have risk factors for diabetes, but we only collected from the hospital. So we don't have a true representation of the problem in the community. So let's talk about an example of representativeness. So here we see an example of this. Now this map shows the percentage of deaths over age 30 by tobacco in 2004. Now the data used to create this map was collected from mortality surveys conducted only in the capitals of each country. So if this was done in Fiji, they only would have gone to Suva. If this was done in the Federated States of Micronesia, they only would have come here to Pohnpei. Okay, so do you think the percentages in this map are representative of the true occurrence of deaths caused by tobacco in each country? Well, think about that for a minute. Why or why not? Okay. Now, it's highly unlikely that the data are representative of the true occurrence of disease caused by tobacco in each country. And the reason for this is that tobacco use and a variety of contributing factors related to tobacco use are going to differ widely between large urban centers like capital cities and rural, village, and outlying areas as well. So the percentages shown in the map may be an underestimation or possibly an overestimation of the true occurrence of tobacco-related deaths in each country. So representativeness is a significant concern in terms of ability of our data to show the true larger problem. Now, one other element to this concept of representativeness. Now, inconsistent case definitions can also be an example of representativeness not being present. Now, case definitions use a standard set of criteria used to ensure that all disease reporters are reporting the same condition. So if it's a communicable disease system, and let's say we're looking to report on leptospirosis, okay, then we want to make sure that all of the clinics, all of the physicians, both public and private, all of the laboratories, both public and private, and so on and so forth, are using the same definition of what leptospirosis is, okay? Because if they're not using the same definition, then once again, the data is not going to be representative, because we might see that one physician has a more liberal definition of what leptospirosis is without, laboratory confirmation, of course, whereas another physician might have a more strict definition. So the more liberal physician might report more suspected but not laboratory confirmed cases, whereas the physician with a strict definition may report fewer but not laboratory confirmed cases of leptospirosis. Okay, so we need to make sure that everyone is using the same case definitions. Okay. Now, these case definitions are periodically updated by public health officials. So, for example, a new test or technology may become available to diagnose a condition, and that could be included as a method of disease confirmation in the case definition, okay? Now, if public health officials review trend data and are unaware of changes in the case definition, they may erroneously conclude that the rate of prevalence of a health condition or disease was increasing or decreasing during a period of time, when in fact the opposite is true. So let's look at an example of inconsistent case definitions impacting representativeness. Now, we're looking again at the three leading causes of injury-related death in the United States. And it looks as if the death rate for poisoning is increasing over time and is decreasing for firearms and motor vehicle crashes. Now, take a look at the black vertical dotted line in 1999. Now, this dotted line represents a change in the case definitions for the ICD. Now, the ICD is the International Classification of Disease, and I'm going to talk about what that specifically is on the next slide. Okay, but just keep that in mind. Now, like I said, this dotted line represents a change in the case definitions for the ICD codes for deaths resulting from poisoning, firearms, and motor vehicle crashes. Now, remember on the previous slide I said, well, we see this increase in some areas and decrease in other areas, and we have to ask ourselves, what is the underlying reason for these? Okay, now one of the potential underlying reasons could be a change in case definition. So now that we know that the case definition has changed, how might this have impacted the rates for each cause of injury or death? So as a result, deaths caused by poisoning increased more steeply, whereas deaths caused by motor vehicle crashes decreased. There was little change in the rates for firearms, and it continued to follow the previous downward trend. Now, we can't be sure if these increases or decreases were solely due to the new ICD-9 codes, or was also the result of true changes in the death rate of the population, but it may have played a role. So I mentioned the International Classification of Diseases, ICD codes, okay? And there are a couple of different ways for us to ensure consistent case definitions, but the most common one is to use these ICD codes. Now, we're currently up to ICD-10, which is the most recent edition that's been released by the World Health Organization. However, many jurisdictions across the Pacific and elsewhere continue to use ICD-9 or ICD version 9. Now, as you know, this is essentially the case definition that's used in both clinical as well as epidemiological and research settings. Now, having an accurate case definition, okay, and if possible, the actual associated ICD code from hospital data or from surveillance data can actually make retrieval of information for both clinical and research purposes much easier. And the other reason that my physicians and my nurses will probably be familiar with ICD codes is there's a billing code associated with ICD. So in other words, a lot of insurance companies will only pay a specific amount of money depending upon the ICD-9 or 10 code that is submitted. Well, once again, you've done it. You've made it through. It looks like it took us about 50 minutes to make it through Lecture 5. I want to congratulate you. I do hope you've enjoyed this, and I hope that you've learned something. Okay. As always, I do want to remind you that we're very thankful to the sponsors that I mentioned at the beginning for supporting these lectures. But most of all, I want to thank you for your hard work, your dedication, and willingness to do this. I know that you're busy people, but you've chosen to take time away to improve yourself in regards to epidemiology. So I want to say well done for that. I also want to ask that if you've been given time away from your job during the workday to complete these video lectures, please take a moment and thank your supervisor for their support as well. And if you're one of those supervisors that's given time to people, thank you very much. It is greatly appreciated. Now, as always, to get credit for this lecture, go ahead and send me an email with your 3 learning points, and then get ready for lecture number 6, Prioritizing Public Health Problems, which is going to be released next month. So go forth, continue to do the good work that you're doing, and have a wonderful day.